Good evening. Thank you so much for joining us tonight. This is the Hanley Foundation's Physician Education Series, and Hanley Foundation's mission is to educate, change minds, and save lives. And we're doing that through the Safe Prescribing Initiative, which is geared at knowing the risk and managing the outcomes. Tonight, I have Dr. Brandon Shallop, who is a board certified orthopedic surgeon. He has an incredible resume of work that he's done in the South Florida community and beyond. And so he's going to share tonight alternatives to opioids for pain management. We're really excited to talk about this. Over the last 20 years, opioid-related overdose deaths have increased 500% among 15 to 24-year-olds. And we know right now that opioid abuse is considered a national public health emergency. So we're really excited to talk about what are some of the alternatives for opioids for pain management. So Dr. Shallop, can you share more about your background and experience in orthopedic surgery, particularly in sports medicine and treating teen athletes?
Sure. Well, thank you again, Allison, for inviting me. I appreciate you giving me the opportunity to talk about this subject. As you briefly mentioned, it's a huge problem in the United States. I think we all, as in the healthcare field, need to continue to do a better job to mitigate the opioid abuse that's currently going on in this country. So again, I want to thank you for taking this initiative on and inviting me to talk with you tonight. For my background, so as you mentioned briefly, I'm an orthopedic surgeon here in Palm Beach County. Kind of going back in time, I'll give you a little rundown of my education. So my wife and my family, we both grew up in Michigan, where I graduated from the University of Michigan with my undergrad degree in biology. And then I went on to spend 9 years in Philadelphia. So I did my medical school training at Thomas Jefferson University in Philadelphia for 4 years. And then I did a 5-year orthopedic surgery residency training at Drexel University, still in Philadelphia. And then to pursue a subspecialty within orthopedics, I really enjoy working with the young athletes. So I did a sports medicine fellowship, which really entails working, again, mostly with athletic individuals, but also honing in on surgical skill sets and more minimally invasive techniques, specifically arthroscopic, which is camera surgery for really the knee and the shoulders, really predominantly what I focus on. I did an extra year of that training at the University of Miami down in Coral Gables, where I really had my major exposure working with the athletic team. So I was the co-team physician for the University of Miami for that entire year from 2019 to 2020, where I was the assistant team physician for the Miami Hurricanes football team and basketball team. So I got to travel with them for the entire year, work directly side by side with the coaching staff and the athletes on the field, off the field. I was also one of the team physicians for the Miami Marlins, the professional baseball team in the university or down in Miami. So I got to work with both the collegiate and pro level, which I still do today in certain assets of my practice.
That's incredible. Very busy guy.
It's fun though. I mean, it's a guy's dream. I mean, I never was big enough, fast enough, strong enough to play with the pros. So I was like, I might as well take care of the athletes on the other end.
Yeah, gotta nurse them back to health for sure. So how did your fellowship at the University of Miami Miller School of Medicine, with its culturally diverse patient pool, influence the professional that you've become?
That's a great question. I think the nice thing about a fellowship is you get to treat all athletes of all different ages and brackets and sizes. I mean, obviously I got to work from the highest level up working with pros, but and college D1 athletes, but you also, not only being at the Miller School of Medicine, is you get to see the weekend warriors, you get to see the high school athletes, you get to see the youth athletes. And that's the value of being at a big academic center to do your training, is you get to see the entire plethora of athletic injuries, from youth injuries all the way up to the pro level, which I think gives you a unique skill set on different parts of how to treat an athlete, not just their current level in which they're at.
What is your philosophy regarding pain management for pediatric orthopedic patients, and how would you say it's evolved throughout your career?
So that's a great question. I mean, obviously, pain is a difficult thing because it's a little bit of a subjective thing. One person's pain is different than another person's pain, and we try to standardize things, but the reality is this: every patient's a little bit different, and you have to really be focused on that specific patient's level of pain and accommodate it appropriately. So I've definitely made several changes throughout my career, learning and discussing in different topics on how to treat different people, but you have to look at it on more of an individual approach as opposed to trying to standardize it, because it's just different. But when it comes to more of the younger athletes, or I guess let me rephrase that. I mean, I really think for all athletes, I think the biggest thing that I've taken away is and the adaptations we've done in medicine is looking at pain as a more of a multimodal approach, not just directly starting with narcotics or something like that. There's a whole plethora of different non-narcotic based medications that can really assist with pain. Additionally, the adjuncts of simple things as icing. Icing is underutilized in my opinion, and I have now standardized it in my practice that every surgical patient of mine goes home with a on device, a ice therapy device that goes directly over the wound or incisions or everything like that, and it helps tremendously bring down the narcotic use and the acute pain post-operatively. The other thing too is in sports medicine, the rehabilitation following an operation is directly correlated with physical therapy. So there's been more adjuncts in the physical therapy realm that have really, again, helped mitigate pain. And again, on that end, mitigate narcotic use. The TENS units, the STIMS units, the pulse electromagnetic wave devices, laser therapy, ionophoresis, all these different new topical or superficial anti-inflammatory modalities have really changed the game in regards to mitigating pain and mitigating how much narcotic we need to use in these young athletes. Again, the whole goal is to mitigate dependency, or the risk of it at least.
Yeah, that's incredible. I wasn't aware that you all were doing that at the surgery center. I know ice baths are, like a big trend right now, but if you really read the benefits of it, I mean, they go far beyond pain management. It's, physiological, mental health, all of that kind of
Absolutely. There's a
intertwined.
ton
So,
of data coming out on that. I mean, again, working with a lot of the pro athletes, they've now incorporated icing or ice bath into their, the absolute or their standardized regimens. The pro athletes have very regimented protocols in regards to their health, their sleep, their diet, their rehab protocols, and then icing has become like the new craze, and it makes big difference.
oh yeah, definitely. So, adolescence is really a critical time to understand risk factors that may influence the likelihood of misusing opioids later on. And the National Center for Drug Abuse Statistics put out this study, and they said that high school students who legitimately use prescription opioids are 33% more likely to then misuse opioids after high school, which I thought was pretty alarming considering we think that, when someone's being prescribed an opioid, even if they're taking it as prescribed, they still can
Mhm.
develop this, dependency. So, in your experience, what are those key considerations when addressing pain in orthopedic patients who are, young athletes and they're really eager to resume their athletic activities?
Yeah. So again, I think the biggest thing is, well, let me rephrase this. There's several things that I think we have to take into account. First of all, an adolescent is not an adult. All right. So I'm very, very deliberate, and I have very thorough conversations with the parents of this athlete. They are the ones who are in charge of this medication. I made that explicitly. I have a deliberate, I personally have this conversation with every parent saying, you are in charge of this specific medication. You give this only as directed and only absolutely as needed. This is a last ditch resort medication. I prescribe other medications in addition to narcotics. So all of my post-operative patients go home with a high dose anti-inflammatory after surgery. The first one is called Toradol or Ketorolac, which is a very potent non-steroidal anti-inflammatory. I tell patients, adolescents, and the parents, this is a no matter what medication. They take this one no matter what. It helps with pain, swelling, inflammation from the operation. Number two, as we discussed, every single one of my surgical patients goes home with an ice therapy device. Again, no matter what, they use that. The third is the narcotic. And I give a very, very small dose in regards to like milligram dose and a very limited amount of tablets. And I tell the parents, this is only as needed, an absolute only as needed. Otherwise, stick with Tylenol or something along those lines for something a little extra if they need it. I also do a very short-term follow-up with that patient because I'm only giving them a handful of narcotics. I see every one of my post-op patients within 5 to 7 days after surgery. So I lay eyes on them. I see how they're doing, see how their swelling is. And I also acutely get them into physical therapy. Physical therapy has, again, what we briefly discussed, all these other modalities to minimize how much narcotic use. So they had the therapist work on the swelling. They work on the elevation of the leg or the extremity. They work on further icing or deep tissue massage to help bring the fluid and swelling down the leg. Those hands-on therapy plus the anti-inflammatories plus the icing, I found that I have brought my need for narcotic use tremendously down. When I say most patients at this point are taking less than 10 tablets in their entire post-op course.
That's incredible. What would do you in your practice, do you observe that other orthopedic surgeons, do you feel like they're adopting these same levels of care when
I think
prescribing?
some of them are. I think truthfully, I think some of the younger surgeons are more in tune with this as opposed to some of the older surgeons. Now, that being said, having younger surgeons like myself and some of my colleagues in our practice, we've now standardized things. We've made
Yeah.
protocols in place to help these things. Another thing I failed to mention that we've also, besides medications, is most of my surgical patients also get nerve blocks. So we have a great on-site anesthesia department who's very skilled in ultrasound guided nerve blocks, which put long-acting like numbing medicine into different parts of the extremity to help again with the pain. So again, we're trying to attack pain in a multimodal fashion, with narcotics being the absolute last resort.
That's incredible that you all, practice wide have adopted those measures. Um, would you say, can you discuss any cases where, you've known that successfully you've been able to use non-opioid approaches for pain management?
I mean, some of the smaller cases, I don't even give opioids anymore. I mean, a simple knee scope where I'm going with two tiny little poke holes with the adjuncts now of how arthroscopy has become much less invasive. Those patients walk out of the surgery center with very little pain. I only give them anti-inflammatories, the icing, the nerve block, and rarely am I giving narcotics at that point for those smaller cases. What I mean by that is like a small meniscus tear, a labral debridement of the shoulder, or even small like they call slap tears, which is like an acronym for like a biceps tear within the shoulder. Smaller arthroscopic surgeries these days are needing almost no narcotics. Now, larger invasive operations we're doing big ligament reconstructions, ACL surgery probably being the most common that people are aware of. Those are bigger operations. I'm drilling holes in people's bones. That's not a benign thing. That being said, again, to the point we talked about, I think because of all the other things I'm incorporating in, most patients are only needing a handful of those narcotics at most. And they're like, my pain's okay. I don't really need any more of these. And they just say, I have my whole bottle still. I'm not even using it.
So, as far as the minimally invasive techniques such as arthroscopy, how does it contribute to pain reduction? I mean, obviously, if you're drilling into someone's bone or, doing something that way, making it an incision that's much larger, what is the impact of arthroscopy as opposed to traditional or older methods of surgery? How is it that it reduces the pain so much?
It's all worked through smaller incisions, right? So historically, the old school way before the adjuncts of arthroscopic techniques, we'd have to fillet open the entire joint. When
Mhm.
you open up, a substantial incision on someone, there's a significant amount of nerve endings in the skin alone. So by us doing all of our work through a handful of tiny little poke hole incisions that are sub-centimeter in length and doing all the work inside the joint itself, it minimizes the pain tremendously. Despite us still having to pass grafts and drill holes, I mean, it's just the actual work is done through tiny little incisions, which makes the recovery process a lot easier.
So, are there specific cases or procedures that you find minimally invasive techniques particularly effective in managing the pain of adolescents with sport-related injuries?
Yeah, I think there's a couple. I mean, going back to like the meniscal surgery, historically, I mean, arthroscopy has advanced over the last 20, 25 years or so. But before that, again, to get into fix a meniscus, you had to open up the entirety of the knee joint. Now I can do a meniscal repair through two small poke hole incisions, the width of my pinky, and do it within 30 minutes. And so the fact that we can do that quickly through small poke hole incisions and patients on and off the table quickly, the recovery process is much, much faster. The pain is much diminished. And again, adding on all these other modalities, it's changed the game a little bit in regards to the amount of pain patients are having after surgery.
So, how do you personalize pain management strategies based on individual needs of the patients, maybe any other conditions that are affecting them or their age?
That's a good question. I think I've touched on several of those things, but to the initial point I mentioned, you have to make it patient specific because everybody's patient's pain is a little bit different. The other thing too is sitting down and spending time with the patient and counseling on them on several factors. You have to you have to be aware that pain is a reality for these patients. Not only that, they have the mental frustration that they're no longer playing the sport. They're injured currently. So you have to almost be like a sports psychiatrist a little bit and kind of sit down with them and say, listen, we're going to work as a team. We're going to get through this. You got to keep your head up. We have to bury ourselves right now, get through this pain, get through the surgery, get through the rehab. And the goal is get you back on the field. And if you kind of mentally motivate people and kind of walk them through each step of their entirety of their rehab and process to get them back from injury to the playing field again, they just do better. If you sit there and dwell and say, oh, sorry, you have a bad injury, too bad, like they're going to all do poorly. You have to be kind of that coach and guide them and handhold them individually a little bit to kind of keep them motivated to push them through. And you set goals. And by setting those goals and kind of meeting them and seeing the patient frequently, not just say, hey, see me in 3 months. My surgical patients see me a ton, or my PA, that we work as a team, and they see us a much sooner than other patients, because those young athletes need to be coached and they need to be seen. They need to be reassured all the time. If they have that mental feedback helps with the physical pain regimen as well, in addition to all the medications and anti-inflammatory devices we talked about.
Yeah, it's definitely mind over matter, right? Like they're probably feeling so defeated, so worried, especially if, they're a high school athlete that's looking forward to going to college, or a college athlete, wanting to move on. And so, that definitely, having that positive outlook is definitely contributes to their healing, their success.
Huge difference. There was actually even a big study that came out talking about the mental factors that play into the return to play after injury. You need to be that person. They look up to suspicions. Like, you just brought their world down. You pull up an MRI and you say you tore your ACL. It's a season-ending injury, and you're talking about surgery. You can't be very rudimentary about it. You have to say, these are our goals. We're going to work as a team. We're going to guide you through this. We will get you back on the field, but you're going to do your part. I'm going to do my part. We're all going to work together and get your goals to the next level.
Would you say that there are what are your favorite choices of pain management approaches? I know we talked about the ice baths and the icing, and that's
That's
kind of,
number one.
yeah.
The number by far and large, the number one are these new ice machines, right? So what they do is they make your life pretty easy. It's like these wraps. It's like a big Velcro wrap that's custom for the shoulder or the elbow or the knee. That patient lays that wrap and straps it right to that joint. It then has a tubing that goes to basically a big ice chest, and you just put tons and tons and tons of cold water with ice in there, and you plug it in, and it just runs nonstop. Especially for those first few days after surgery. I tell the patients, for 48 hours, you run that absolutely nonstop, because that's the peak inflammatory response the body puts, right? We got to remember that surgery, again, causes pain because it's a organized injury to the body. So the body's going to mount an inflammatory response. It's going to start to heal. It's going to start create swelling and bleeding and inflammatory cells. Icing it down for the first 48 hours makes a tremendous difference. And if we can get them over that first few day hump of the peak inflammatory response, most of the time it gets down after that, and they can minimize how much narcotics you need. So icing by far and large, I think, is number one. That being said, the other two things, again, surgical patients of mine also get nerve blocks, right? So it really helps those first couple of days when their whole leg or their whole arm is all numbed up and they don't feel anything. So if we can get them through that peak inflammatory mark without having to use a ton of opioids, the amount of they're going to need afterwards is negligible. The third is, again, all my patients get a non-steroidal anti-inflammatory, which the most common one I use is called ketorolac or Toradol. Again, a very potent anti-inflammatory medication that helps, again, attack pain in a multimodal regimen in addition to the icing and the nerve block.
And none of those are habit forming?
None.
So are there would you say, any recent innovations or advancements in non-opioid pain management for those who have had to undergone maybe an even major surgical procedure beyond, arthroscopy?
Yeah, so that's where I think a lot of the physical therapy helps us, right? So there's a lot of new devices that a lot of the therapists are using that are really helping mitigating pain. I think I alluded to a couple of them. I mean, TENS units really help, right? So the stim to the different muscles helps, kind of jumble the nerve signals to kind of mitigate how much pain's coming to the leg. There's also newer devices called PEMF devices, which stands for, it's a PEMF, or pulsed electromagnetic wave field devices. And what they do is they help with soft tissue inflammation by using pulsed electromagnetic waves stimulating the soft tissues. Other things are red light therapy or laser therapy. Again, these are all more newer technologies that have been showing in data that they help mitigate inflammatory response. I saw that more so a lot with the high-end athletes that I did, like when I was in the University of Miami. The University of Miami football team traveled with 4 laser devices.
Hmm.
So during the recovery phase, we would be using these lasers hands-on with the physical therapist who would travel with the football teams and helping mitigate inflammation, right? Football's a very pounding, abusive sport. You play on Saturday, you have to play the next Saturday. You have a 1 week to recover. It's a short amount of time when you're getting banged up. So they use all these other modalities to help bring swelling and inflammation down, with the whole goal of getting that athlete from 1 week to the next. Um, Obviously, that's not as common in the community setting or high school setting yet, just because of cost factors. But there's a lot more technology that's coming out, and as time goes on and data comes on, those prices are going to be coming down and becoming more cost available to the community.
So I know you touched on, with the pediatric population, educating the parents and then also educating the pediatric patients. What type of screenings or risk assessment tools do you use within your practice, or do you use any, or is it more so just educating the
I
patients
don't
and
use
the
a ton
parents?
of risk assessments directly per se. I mean, I think a lot of it is asking the patients their medical history. Have you ever used opioids before? Have you ever used narcotics before? I mean, that's pretty much my main screening tool, because I want to see if they've had these or if they've had experiences taking these medications, not only from their baseline of what is their understanding of narcotics and what is their education level on narcotics and how they've used them before. But again, with the younger athletic population, I mean, unless they've had another injury, most of these patients are pretty much narcotic naive. So again, you don't want this to become a habit thing. So I try to minimize how much medication I'm giving them, number one. And number two, again, these are not adults, most of the patients I'm dealing with. They are not the ones in charge of their medication. I deliberately have a formal sit-down conversation with their parents about the risk factors of these medications and minimizing how much they use them. I almost try to scare them a little bit in an educational way. And I found that the power of that has minimized how much patients need and use. And again, I think I'm using less narcotics than most, but I just think it's just the educational value, but also adding on all these other modalities to help minimize the pain.
So those pediatric patients who, maybe they opt for the non-opioid pain management strategies and compared to those who opt for it, would you say that you see more families that are not using the opioids than
Yeah,
opposed
I don't
to
think it's
having
like they're
to?
opting in or opting out per se. I have a pretty
Mhm.
much standardized regimen now, like we talked about. So it's in the cold therapy, the nerve block, the anti-inflammatory, and then I always give a little bit of narcotic because like if I do a lot of my surgeries on a Friday, if they go up,
Mhm.
if they're home on the weekend, I want them to have something. God forbid they're like really, really uncomfortable.
Yeah,
But I find that most patients come that first week post-op, and I ask them about their pain, like it's tolerable. I'm like, oh, okay. How much of the narcotics do you use? Oh, we haven't even opened the bottle,
that's amazing. Yeah, that's
or maybe used one or two. Like it's very trivial at this point.
yeah, I think, in the work that we do, we're always seeing the crisis and, and right in front of us. And we're often, encountering people once they've already developed a habit. And so it's kind of, we try to do full circle, right? Like we try to do prevention, education, advocacy, and treatment. But then sometimes we feel like, man, I really wish somebody would have talked to this person way before it got to this point. And so, it's amazing that you all are doing that as prescribing physicians because there is no standard for prescribing the pediatric populations. There's all these, standards and guidelines for adults, but there's nothing that's been released, officially with the CDC that's specific to pediatrics. So you mentioned, you're a parent and an orthopedic surgeon. So how do you stay informed on the latest developments in non-opioid pain management in pediatric patients?
Yeah, it's just staying current with the literature, right? So I mean, I wouldn't be doing due diligence for my patients if I'm not staying up to date. I mean, it's you and I are talking right now. It's 8 o'clock at night, right? So my kids are in bed. We're doing these things. I sit down. I read medical journals at night before I go to bed. I mean, I have to stay current. I mean, I think it's the only way to be doing the right thing long term for your patients. Not only advancements in surgery skill sets, pain management approaches, trying to get better outcomes for your patient. Pain's part of that. All right. I
Yeah.
mean, I mean, if they have a stable knee but they hurt, what did I do for them? Right. So it's all the factors involved.
So what would you tell colleagues in your profession, in orthopedic surgery that work with youth for, whether they're athletes or just injuries in general? What advice would you give to them when it comes to safe prescribing practices?
I think the key is making these standardized protocols. So I learned a lot of this in fellowship. University of Miami, being a big academic center, did all this. So they had nerve blocks on every patient. They had cold therapy on every patient. They gave high dose anti-inflammatories every patient. They had protocols. I think it's important you start that most surgeons adopt some level of a pain management protocol, with the narcotic being the last end of that straw, right? I've adopted that. I brought that into my practice when I first started 4 years ago. And most of my colleagues have seen what I've done in my practice, and now we've basically adapted that throughout the entirety of our practice, which is now 16 doctors. And so I think taking some of the education from your other training sites and incorporating it into your habits, into your regimen, into the community that you're then working in, can do powerful things.
Yeah. So you would say overall, other physicians are pretty receptive.
I think they are. I think most physicians these days are really aware of the opioid issue,
Yeah.
and they're now much more hesitant to give opioids, which is reason. I agree with that. I think we should be. I think we should be really questioning how much opioids we give. But I think it also, you can't just say, "Oh, too bad." You can't. Oh, you're in pain. So what? Suck it up. Like, you have to address the issue, and there's other ways of doing that, and that's why I think it's important to really be in tune with how to incorporate these other modalities into your workflow, into your patient care, into your surgical workflow, to help, again, make the patient comfortable so they're not needing or wanting those higher level medications.
Well, this is such good information for me as a parent of a teenager who's not an athlete. So I don't have to worry about this per se. But the work that we do, thank you so much for your expertise in this. Thank you so much for what you all are doing. Within your practice, I think it's really setting a standard, and I'm hopeful that other physicians in the area who maybe haven't adopted standards or guidelines will, after reviewing this video, and recognizing, like you said, there's other ways to treat it, with having an opioid as a last resort, having it there if needed, but there's so many other things that you can do to minimize the pain. And so thank you so much for being with us tonight. We really appreciate you. This is great information, and I'm sure it was great learning for me, and I'm sure it'll be really helpful for those who are viewing this as well.
I appreciate you taking the time. I'm happy to talk about these things. I find I'm very passionate about the young athlete. So I take this wholeheartedly. I think this is an important part of my job responsibilities, to help mitigate the risks and the ramifications of what I'm doing. Again, prescribing opioids being one of those things. This is a real problem in the United States. We all need to do better about this in regards to our prescribing habits, our treatment modalities, and education. The key is, I think, as doctors, we kind of get away, we get so busy and running and trying to see as many patients as possible, but sit down, talk with these athletes, talk with the parents, educate them on the risks of this. If you teach them that, my personal experience with that is they're using them less and less. And I think the risks that can be tremendously brought down.
Absolutely. Well, thank you so much. I really enjoyed this.
You're welcome. Thanks, Allison. I appreciate your time as well. And thank you for inviting me on the show.
Thank you.